Hello, Connecticut, and welcome to the Paid Leave Podcast. The title basically says it all. I'm Nancy Barrow, and I will be delving into this new state program and how it can help you and your family. This podcast will give you information you should know about Connecticut paid leave and maybe just a little bit more. Connecticut paid leave brings peace of mind to your home, family, and workplace. Welcome to the Paid Leave Podcast. The podcast today is on breast cancer. We're talking about breast cancer because October is Breast Cancer Awareness Month, and we focus on this topic because Connecticut paid leave gives up to 12 weeks of income replacement, so you can take time away from work to deal with your own serious health conditions or that of a loved one. So whether you're the patient or the caregiver, Connecticut paid leave can let you focus on healing or helping and not worrying about your finances. I lost my mom to breast cancer when she was 59. She was diagnosed with stage 1 breast cancer when she was 47. And she was among the first patients over 39 years ago to have a lumpectomy and radiation, as well as being on tamoxifen. And joining me today is breast surgeon Dr. Kertrisa McWhite, who's a fellowship-trained breast surgeon at the Middlesex Health Surgical Alliance and the Comprehensive Breast Center. And you specialize, and let me see if I can even say this right, intraoperative tumor localization using ultrasound and radio frequency devices, which sounds really cool. And she also has experience with the placement of radiation brachytherapy devices. Did I say that all right?
Yes, you did.
Well, thanks for joining me. I so appreciate you being here.
Oh, my pleasure. Thanks for having me.
Did you know you always wanted to be a doctor? Was that something that you knew pretty young on?
You know, it's interesting that I get asked that question quite often, and the answer is probably surprising to most. The answer is yes. I always knew I wanted to be a doctor. According to my dad, I was about 4 when I started to advertise this fact, and I stick to my guns. So, yeah.
That's so interesting. And so you knew right away. So did you kind of go towards all the sciences when you were studying?
Definitely. Now I'm an avid reader, and so I certainly didn't mind my, literature classes and my writing classes, but science was my first love.
I love hearing stuff like that you knew exactly what you wanted to be. I had no idea. I wanted to be a vet. And then my first biology class, we had to do something with a fetal pig, and I was like, this is not for me. This is not my avenue. I know you're a really big advocate for breast screenings. Which ones do you think are the best, or is there a best? Mammography, ultrasound, MRI, breast thermography? What do you go to?
So there's no one best test for everybody. Every patient is different in their breast density, the types of breast tissue you find in the breast of, one patient who's age 35 compared to another might be drastically different from what you see in a patient who's 85 years old. And so it's really the combination of imaging modalities plus physical examination that is crucial. I think that we certainly should not move away from mammograms and ultrasounds as our main line. MRIs are very useful for patients who have dense breast tissue, and for patients who we have a high level of suspicion for cancer or have done a needle biopsy and have actually diagnosed breast cancer. Breast MRI is a wonderful tool to help us to establish the extent of disease. It allows us to view both breasts with that one study and the underarm areas, the chest, the upper liver. So it has its role. It should not, again, replace mammography. And then other techniques like molecular breast imaging or thermography, which are perhaps less known, they can play a role as well. We do offer molecular breast imaging at Middlesex Health, and I'll give you a scenario where it might be helpful.
Okay, yeah.
I see a patient who has lots of changes on her mammogram, enough to warrant a biopsy. She has a needle biopsy, and we diagnose breast cancer. Well, this patient also has a pacemaker, and we can't obtain an MRI. And I'm concerned that maybe the mammogram and the ultrasound didn't show the full extent of disease. In that scenario, I might want to do some molecular breast imaging to make sure that we're not missing anything on the previous studies.
I know that you mentioned someone who's 35. Are you noticing women being younger getting a diagnosis these days, or is it pretty much the same across the board?
I think that we are diagnosing breast cancer earlier, and women, because of the great education campaigns we're using, are more aware, more proactive about their health. I think that, the women that I see who are in their 30s or early 40s with a breast cancer diagnosis, maybe 20 years ago, I would have been seeing them at age 50 with an advanced breast cancer instead of at age 35 or 40 with a non-invasive breast cancer or a 1 centimeter breast cancer.
Let's talk about the different types of breast cancer. There seems to be so many, like HER2 negative, HER2 positive, encapsulated. Are there a lot of different types of breast cancers?
So when we talk about invasive breast cancer, there are two more common types that make up probably 95% of the breast cancers. There's invasive ductal carcinoma and invasive lobular carcinoma. And that doesn't mean that one is necessarily better or worse than the other. That's really just describing the type of tissue where that cancer arose. So the lobules of the breast are the milk-producing sacs, and attached to those sacs are tubes that would carry the milk to the nipple, the ducts.
Right.
And that tissue, the lobular and ductal tissue, is more metabolically active. Those cells turn over quite often. And so it would be more likely that a mistake would happen in the development of one of those cells that would eventually lead to cancer versus, the fatty tissue or the connective tissue that makes up the breast. That's not to say that breast cancers cannot develop in those areas. They can, but that's why it's so much less common. And then there is a third entity, an in situ or non-invasive breast cancer that we call ductal carcinoma in situ, or DCIS for short. And that is a cancer. However, the cancer cells under the microscope are limited to the ducts. The cancer may travel up and down the course of the ducts, but there's no evidence of cancer cells that have pushed their way out of the ducts and into the surrounding tissue. And that's a really important distinction, because with true DCIS, I can just scoop that little area out, get a little extra tissue for safe measure, and surgically we're done. We don't have to worry about where else that cancer might have gone, because again, we know it's in situ. It could only have gone up and down the length of the ducts. With an invasive cancer, we need to make sure that we're addressing the cancer in the breast, but we also need to investigate and sometimes surgically address areas like the lymph nodes and organs like the liver, the lung, the bone, and the brain. Those are the four most common sites of metastasis for breast cancer. Anyone having a breast cancer operation for invasive cancer is going to have some lymph nodes surgically removed at the same time as their breast operation, whether that's a lumpectomy, just removing the cancerous area, or a mastectomy, taking the whole breast.
Let's talk about that. Like, how do you figure which way to go with lumpectomy and radiation versus a mastectomy?
So I'll tell you, a lot of it, fortunately, is patient choice. If I have a patient come in with a smaller breast cancer, regardless of the size of her breast, I'm more than likely easily able to offer her a lumpectomy if that's her choice, versus saying, you know what, this tumor is a little too big. If I take the tumor out plus a margin of safety, I'm not going to leave you with a breast that you feel is still attractive. Maybe we can consider, something more aggressive like a mastectomy.
Yeah.
I hate that conversation.
When you do the mastectomy, who does the reconstruction? And do you do reconstructive surgery as well?
So I don't do reconstruction,
Okay.
but I work with a great plastic surgery team.
Yeah.
They are based down at the shore, but they happily come up here to Middlesex to operate for me for my patients.
That's wonderful. Let's start with someone who maybe gets a mammogram this month because it's, October and Breast Cancer Awareness Month. And it turns out that she has breast cancer. What would you tell her to be her first move after a diagnosis?
So typically when I sit down with a patient who's newly diagnosed, we will review her pathology results. I will talk about the cancer type. I make sure that I describe and explain some of the terminology on that pathology report, because I'm sure when you're frightened and worried, looking at those pages is like reading Greek.
Right. And you don't hear anything, right? When that diagnosis comes, you're probably like, oh, that's all
Exactly.
you heard.
Exactly.
Yeah.
Of course, I always ask patients to bring someone with them so they have a second pair of eyes and ears. But we will talk about, things like the size of the tumor, whether it's invasive or non-invasive, the status of the patient's hormone receptors on those abnormal cells, and other test results that might be pending. Then we'll talk about whether there's any additional imaging that might be helpful to us before a surgery decision is made, whether the patient is interested in obtaining genetic counseling and doing genetic testing before making a surgery decision, and whether the patient has any inkling that she might opt for mastectomy so that we can get her in to meet with plastics right away.
Are you finding that more women are opting for that, or is it pretty much split?
Again, funny that you asked, because I feel like lately I've had more patients opt for mastectomy than lumpectomy.
Mm-hmm.
And, it's not because they're being diagnosed with more aggressive breast cancers. It's not that they are worried so much about cosmetic results of a lumpectomy. I think that women are just deciding that in some cases they would feel more comfortable, have less worry going down the road about breast cancer if they just had the mastectomy with reconstruction.
Yeah, I think my mom had some regrets about that after she had her lumpectomy and radiation. But you don't know. You just don't know. And it's what your comfort level is.
That's exactly right. When I meet patients for the first time, most of the time, we're not in such a hurry to get treatment started that they can't take, a moment, a few days or what have you, to make their surgical decision. So, I say, I'm not asking you to make any tough decisions today. Let's gather this additional information and then decide. And so, I think a lot of patients research very well and decide that that's the best thing for them.
The internet can be a blessing and a curse, though, when you're
very true, very true.
when you're
run into
searching.
that all the time. That's the patient that comes to visit me who has one of those single subject notebooks, but it's full of notes from the internet already. Yeah.
And do you encourage that? You encourage them to ask certain questions. I'm sure you say,
definitely,
go think about it and ask some questions and come back.
I love a list. And so I like it when patients write down their questions and then we can go through every question. And I also encourage patients to call back after they leave, because I guarantee there are going to be a few questions that they forgot to ask either in that moment or think of later, as time goes on, as we're waiting for those additional tests and results to come back.
Right. How much does family history matter to a diagnosis and treatment?
So most breast cancer patients have no family history of breast cancer.
Yes, my mom.
All.
Yeah, none.
And so, as proud as I am that we've done a great job educating patients, especially those who do have a family history, who may have a genetic mutation in their families, I think it's come slightly at the sacrifice of reinforcing the idea that you can be without any family history at all and develop breast cancer. I haven't heard often, but I've heard often enough that I'm always thinking about these women who come in, who tell me, but I don't have a family history, so I just never thought it could happen to me.
Right.
And I'm telling them, you are like most of my patients. So, I think we have to do a slightly better job. Yes, if you have a strong family history, it's important to do these things, but even if you don't, it's just as important that you do these, routine screenings and talk to your doctor, have an ongoing conversation about the health of your breasts.
And how young would you tell someone to go and get a mammogram?
So if you have a family history of breast cancer, you should start obtaining your imaging about 10 years before the youngest person in your family was diagnosed. So if you have a relative who was diagnosed with breast cancer at 37, well, then you need to start your routine screening at age 27. So that's a long time before you would normally start to do your imaging.
Yeah.
And I think there are many, many patients who have no idea that that's the standard recommendation.
Yeah, I didn't know that either. I started a little bit earlier than that just because I was in my 20s when my mom passed away from breast cancer, and I was a freshman in college when it all started. So, clinical trials, how important are those?
They're very important. I mean, one of the tests that we rely heavily on now, there's actually more than one test, but the one that we use most often is a test called Oncotype DX. And we use that test, really the medical oncologists use that test to help determine whether patients who have breast cancers that traditionally would have always been treated with chemotherapy, we help determine whether there are patients who can actually skip or forego the chemotherapy.
Wow.
And that is looking at the DNA of their actual tumor. So samples of their breast cancer tissue are sent out to the outside labs. The components of the tissue are broken down into their smallest pieces, and then a DNA profile is created, and that can be compared to the profiles of thousands and thousands of women who participated in the huge national clinical trials that were conducted in the U.S., primarily starting in the 80s, but they're ongoing. So those are the NSABP trials and some others. Basically, even 20 years ago, 25 years ago, 30 years ago, when women were agreeing to participate in breast cancer trials, their breast tissue was saved. It was stored, it was preserved and saved to allow time for technology to advance to the point where we could come up with these amazing tools to help us determine which patients, could skip chemotherapy. And I think that the advances that we're seeing are going to be exponential. And a lot of it will be based on women who are enrolling in clinical trials now, as well as those patients who enrolled in clinical trials years and decades ago.
Yeah, so vitally important. Have advances in chemo changed? Because I know you still use adriamycin and Cytoxan, which are ones that my mom used, and the ones that notoriously you lose your hair. Are those still being used?
So they are still being used, and they are, tried and true.
Yep.
There are, I think the biggest difference you might notice now compared to your mom's experience is that there are several additional medications, and there are many more combinations of medications. And in addition to that, there are dosing schedules that have been devised that hopefully decrease the toxicity and the side effects of the treatment, but at the same time, maximize the effectiveness. So for example, maybe when your mom went through chemotherapy, she had a chemo session once a month, or maybe 6 months or 8 months. So now a patient just like her would probably have chemotherapy every 2 to 3 weeks over the course of 2.5, maybe 3 months. We call that dose-dense chemotherapy. So we know that giving the treatments closer together actually leads to better outcomes.
It's amazing what's happened in the last 30 years, and I'm excited to see what happens in the next 30. I mean, do you think that we'll ever find a cure? Are you confident, or are you confident that if someone comes in and gets a breast cancer diagnosis, they're not going to panic?
Oh, I'm confident of that, but I don't think a cure is outside the realm of possibility. I don't know about my lifetime, but I don't think it's outside the realm of possibility. I mean, in addition to those traditional chemotherapy medications, we also have many medications that have already been approved for use, not just for breast cancer, but for other cancers, that are more targeted therapy.
Right.
They're medications that, instead of just killing all cells that are copying themselves rapidly, which affects your intestines to cause diarrhea, or your mouth to cause, sores, or your, skin to cause your hair to fall out. We have medications that act on, specific mechanisms within those cancer cells. So it's only the cancer cells that are being affected.
That's so cool.
Yeah. I mean,
is that DNA targeting, or how do you figure that out?
It is not so much DNA targeting, but they use monoclonal antibodies and just so many things.
Wow.
It would be wonderful if we had a medical oncologist who could talk about all of the new advances in chemotherapy drugs.
Yeah.
I would defer to them, but there's definitely room for optimism and excitement on the chemotherapy front.
That's fantastic to hear. It really is. How important is physical and emotional health when you get this diagnosis? Do you encourage women to have a really good support system, or to get into therapy, or do you talk to them about those things?
Definitely. I think it's crucial because, this is a huge burden to bear. It's scary. It's right up there with, all of those other devastating life events, the loss of a loved one, a divorce, etc. I mean, nobody ever wants to hear that C word associated with them. I mean, your thoughts you can't help but have your thoughts go to dark places when that happens. So I think family support is crucial. We do have a variety of behavioral health options that can allow a patient to connect with someone to talk about those strong feelings and emotions that, are naturally associated with a cancer diagnosis.
That's one good thing about Connecticut paid leave, is that it's sort of built for the caregivers to take time off to help someone with that diagnosis. And they get up to 12 weeks of income replacement. So they don't have to worry about, I can't leave work, I can't take you to your doctor's appointment. That's one of the things I love about Connecticut paid leave, that it really gives caregivers and a family options, even the patient options, if they still want to work, and they can take time off and not lose their income.
That's right. Patients aren't driving themselves to the hospital on the day of surgery, and they're going to need, help with the practical things in those first several days when, they're not getting around very well, and taking those trips to and from appointments at the breast center, the hospital, etc. That's a time-consuming issue. And so, yes, family members do need the flexibility to be available for their loved ones.
Yeah, it's wonderful that we have this in Connecticut. We need it nationwide, but we're really fortunate that we have this in Connecticut. And I hope that we can get all that information to your patients, or we'd love to help let them know that there's other options out there for them.
Yes, I'd love to have something that I could put up in my exam rooms and at our front desk so that patients could pick it up and read it when they're in between visits and that sort of thing.
Well, I'll bring them down. I'll bring them down to you. Are there ways that we can prevent breast cancer, or guidelines for us to follow, like exercise? I know low-fat diets. How much is environment and stress contributing factors, or is it really just, diet and exercise?
No, I can't put a number on it, but what I can tell you is that carrying excess fat, for want of a better term, does increase the risk for breast cancer. But then there are other things like, tall height that increase the risk for breast cancer.
Hmm.
It's not something that we necessarily understand precisely, but I think that anything someone does to improve their health, whether it prevents the breast cancer or makes them a healthier patient if the breast cancer is diagnosed, is a benefit.
A tall person?
Don't ask me where they came up with that.
Wow. Like how tall? Like what do they consider tall?
I don't know. This is something I saw on a long list a long time ago,
Wow,
but
that's really incredible. I know Black women have a higher death rate from
that's
breast cancer. Tell me about that and why that happens.
so the biggest factor is something you kind of touched on a little while ago. We were talking about hormone receptors, and I didn't go into detail, but one of the other features we commonly look at with breast cancer is a protein that's a normally occurring protein in breast cells called HER2. Some patients have cancers that have an excess of that HER2 protein, and those cancers are sometimes more aggressive. So, that's, the bad. The good is that we actually do have medications, great medications, to treat those patients who have the HER2 positive breast cancer. In contrast, for patients who don't have that HER2 protein and also don't have the positive estrogen receptors, which we treat those breast cancers after surgery with tamoxifen or Femara or one of many drugs that block estrogen receptors. For patients who don't have either the estrogen receptor or the HER2, we don't have as many things to target their breast cancers, and those breast cancers can do less well. We call those triple negative breast cancers.
Mm-hmm.
No estrogen receptors, no progesterone receptors, no HER2. So it gives us less tools, less tricks that we can pull out of our bag to fight those breast cancers. And African American women are more likely to have that triple negative breast cancer.
Is that a genetic makeup?
There must be a genetic component, I believe, but there's nothing that's been proven. In addition to that, African American women are more likely to be diagnosed with breast cancer before age 45. So, you have that, 20 something year old, that rare 20 something year old, that, 30 or, late 30 something year old who's, busy with everyday life, chasing kids, working at her demanding job, who it has never passed her mind that she might develop a breast cancer.
Right.
And she's got a history of breast cysts or benign breast lumps. And so when she feels a lump, she's like, oh, well, it's probably just a cyst. Let me, get back to carpool.
Yeah,
and,
right.
A year later or 2 years later, when that cyst is, a golf ball sized lump in her breast that she can't, ignore any longer, she's diagnosed with a more advanced breast cancer.
Yeah. Are you finding that there's mistrust in the healthcare system with African American women?
Sometimes.
Yeah.
I think that as time goes on and patients are able to educate themselves from a variety of sources like this podcast and, reliable sources on the internet, I think that patients who are hesitant or doubtful do have places to go to be reassured. At the same time, if you go down the wrong rabbit hole, it's possible to convince yourself that, everything we're offering you is, not the choice you want to make. But yes, there is, I think, sometimes a bit of distrust. I think once patients sit down with me, I think they're able to put those fears aside and just understand that we're going to go on the journey together.
Yeah. Let's talk about genetic testing just for a minute. The BRCA test, I was terrified to get it because I knew if it was positive, I'd have to do something, right? Like the Angelina Jolies of the world or Christina Applegates of the world. They were
Right.
BRCA positive, had double mastectomies, and got rid of their ovaries. So I had to make sure that I was ready for that decision. And just for everybody to know, if you've never done the BRCA test, it's a spit test. It's nothing painful or invasive or anything like that. And I am BRCA negative, which gives me relief in a way. But do you think sometimes that is something I shouldn't have? I should always be on guard? Or do you think that the BRCA negative gives me some breathing room or gives women some breathing room when they are negative?
I think it should definitely give some breathing room, but just remember that that means that your risk is closer to that of the average woman.
Right.
And that risk is about 12 to 13% that in your lifetime you might develop breast cancer. So 1 in 8 women in their lifetimes will be diagnosed with breast cancer. I will point out that since you did that testing those many years ago, there are now more than 80 mutations that we can test for.
Wow.
Either have or we believe may have some effect on breast cancer risk. The BRCA mutations potentially carry the highest risk for development of breast cancer, somewhere between 45 and 80%, depending on which BRCA mutation. Some of the other genes that we might see are the PALB2 mutation, the CHEK2 mutation, and many, many others. It's also important to know that if you're diagnosed with one of those mutations, you could go your whole life and never have a problem with the breast. You could go your whole life not have any, a big surgery and be fine.
I really think that right now, genetic testing and finding someone who's a genetic counselor or something to find out what your risks are, I think is really cool and very interesting.
Yeah, I mean, if you are worried that there's something in your family history that might put you at increased risk, you need to have a conversation with your primary care doctor. Ask for a referral. A referral doesn't obligate you to anything. You'll sit down with a genetic counselor and review, hopefully at least a 3-generation family tree, listing any relatives that have had cancer of any type. Because even though I named those, the big 4, the breast, colon, pancreatic, and ovarian, there are other cancers that are associated with other mutations that, once we see that profile would give us that reason to be suspicious and do further investigating.
Well, it's been so interesting talking to you. I could talk to you forever. I mean, you're just a wealth of information, and I really appreciate you being on this podcast.
Yeah, it's my pleasure.
Dr. Kertrisa McWhite, a fellowship-trained breast surgeon at Middlesex Health Surgical Alliance in the Comprehensive Breast Center. How can they get in touch if they need to? Is there a way to get in touch with you?
Yes. If you want to get in touch with me, you can call my office. The number is 860-358-2780.
Thanks again for coming on the podcast.
Thank you.
If you would like more information about Connecticut Paid Leave or to apply for benefits, please go to connecticutpaidleave.org. This has been another edition of the Paid Leave Podcast. Please like and subscribe so you'll be notified about new podcasts that become available. Connecticut Paid Leave is a public act with a personal purpose. I'm Nancy Barrow, and thanks for listening.